HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Today I'll be speaking to clinical haematologist Dr. Nicholas Webber about myeloma, and we're going to discuss the epidemiology of myeloma, clinical features, investigations, and when to refer. I shall be recording another podcast about myeloma, including initial and maintenance therapy, possible treatment complications, and vaccinations. Dr. Nick Webber is a haematologist at the Royal Brisbane and Women's Hospital and senior clinical lecturer at the University of Queensland. He has a clinical interest in plasma cell disorders and is involved as a clinical investigator in a number of research activities in this disease group. In his role as the chair of the education pillar of the Medical and Scientific Advisory Group for Myeloma Australia, Nick advocates for education to raise awareness and promote empowered decision-making for patients and families living with myeloma. Nick, welcome, and thank you for joining me for today's Health Ed podcast. Let's start with you telling me a little more about yourself.
Thanks very much for having me on the podcast. I think you've summarised it. I am a full-time public haematologist at the Royal Brisbane and Women's Hospital in Brisbane. And I did all of my training in Queensland, went into haematology directly from my basic physician training, and was really quite drawn to plasma cell diseases as a subspecialty within haematology during my training. I think just because the spectrum of pathology that we see in this disease group and the number of different ways that patients present is really fascinating from a basic science perspective. But also I've been really lucky that the advances in this area in the last 10 years have been phenomenal, and the access to therapies that we now have and that we will have in the coming years is so exciting that it's a disease that I really feel like we're making a big difference in.
Well, Nick, myeloma is one of the more common blood cancers, but still has a relatively low prevalence. So GPs may not see it very often throughout their clinical career. I wonder if you could briefly outline some of the sort of basic biology and the current epidemiology of myeloma in Australia, including some of the risk factors that GPs should be aware of.
That's right. I mean, I see myeloma every day, so it's a very different focus from what GPs are seeing on the front line in community health. And we've all heard about myeloma and studied it in our pathology training in medical school, but as you say, many GPs will not see a case, for years in practice. And I guess that's one of the reasons why we're trying to promote more education at the GP level, because these disorders are more common than we think, and the prevalence of plasma cell dyscrasias, not necessarily myeloma, but precursor conditions like MGUS and smoldering myeloma, is up to 5% of the population over the age of 40. And that's some statistics that have come out of a really large study in Iceland, where they screened pretty much half of their adult population and found that up to 5% of people carried evidence of plasma cell dyscrasia in their blood. In Australia, myeloma is really the stage that this disease gets recognised most commonly because patients present with symptoms, and the incidence is about 2,500 cases per year around the country. At the moment, the prevalence, that is the number of people in Australia living with myeloma, is about 20,000, we think. So compared to things like prostate cancer and breast cancer, that's obviously a relatively uncommon cancer. We also see that the incidence of myeloma increases with age. So most of our diagnoses are being made in people in their 60s and 70s. And in that age group, other comorbidities are often a competing factor and can often contribute to delays in diagnosis or misdiagnoses altogether. In terms of epidemiology, otherwise, we are seeing quite encouraging results from our national myeloma registry that the life expectancy is actually increasing for myeloma. With some of the therapies that I referenced earlier, we're seeing that the average survival from diagnosis for all age groups taken together is around 6 to 7 years, which is a much longer survival from what we were seeing, back in the 1990s, early 2000s. So there's a lot of optimism for therapy in this disease, which contributes to, our desire to diagnose it sooner and get people recognized and get them treated before they become permanently incapacitated or die from the condition. You mentioned, the biology of myeloma, and it's quite a predictable progression. Myeloma originates from plasma cells, which are the white blood cells in our bone marrow that produce antibodies. So plasma cells in the marrow are usually around 5% of the total cellular type, and their role is to mount immune response to infections, to vaccinations, and to produce antibodies. When those plasma cells, if those plasma cells become mutated and develop the ability to undergo malignant transformation, so they lose their ability to function normally and become proliferative, aggressive, and start to behave like a malignant clonal population, we see those cells proliferating within the marrow and causing a range of different pathological findings that we give the initials CRAB, C-R-A-B. So that's the traditional high calcium anemia, lytic bone lesions, and renal failure. Myeloma is obviously the terminal presentation of that process, but we know that the mutations that we see in myeloma are actually present in plasma cells of these patients many years in advance of that diagnosis, during this phase of what we call monoclonal gammopathy of undetermined significance. So MGUS was coined to describe the finding of monoclonal proteins in the blood of patients who were asymptomatic and who didn't have any of those CRAB features. And we know that all patients with myeloma had MGUS, but only a small proportion of patients with MGUS proceed to myeloma. So the challenge is identifying those patients who are at high risk of progression or who are in progression to myeloma and catching those patients before they become unwell.
What is the other category, though? Could you speak about smoldering myeloma and the difference between MGUS and smoldering myeloma, and then the diagnosis of myeloma?
So, smoldering myeloma is the intermediate phase between MGUS and multiple myeloma. It's really just a way of describing patients who have accumulated a higher burden of abnormal plasma cells in their bone marrow, or a high protein concentration in their blood above 30 grams per litre, but who don't meet those clinical features to diagnose them as multiple myeloma. So the smoldering myeloma group are patients that we watch a little bit more closely because their disease burden is increasing. Their rate of progression to myeloma is higher than those patients with MGUS. And there's a lot of focus now on identifying high risk smoldering myeloma patients and potentially treating them before they develop myeloma, which is an active area of research around the world at the moment.
So you've mentioned sort of this abnormal proliferation of plasma cells in the bone marrow. Can you just remind us again, back to basic biology, these plasma cells produce an abnormal immunoglobulin known as a monoclonal or paraprotein. What are the different types, the heavy and the light chain
Yeah.
types?
So these are antibodies. So antibodies are formed of two heavy chains and two light chains. So these are protein subunits that are produced independently, and then they're assembled inside the cells before they're released into the circulation as immunoglobulins or antibodies. And in our normal immune repertoire, we've got thousands, hundreds of thousands of different antibody subtypes that recognize different antigens. And that's what we'd call a polyclonal repertoire. So they're genetically slightly different. They recognize different targets. And when we run them in the laboratory on an electrophoretic strip, we see a smooth range of lots of different subtypes. If we have a malignant plasma cell process, these are genetically identical cells that are producing the same antibody, and that shows up as a spike on our electrophoresis. It's an increased concentration of a single antibody type, and we call that a monoclonal paraprotein because it's being produced by genetically identical plasma cells. And that's the marker of cancer in this condition. Evidence of clonality that these plasma cells are genetically related and they're doing what they shouldn't. They're growing and they're overproducing antibody.
And that type of antibody could be an IgG, AMED, is that right?
That's right. The IgG subtype's the most common in healthy and in myeloma patients. IgA myeloma is probably the second most common, and IgD, IgE, IgM are quite rare. We can also see patients whose myeloma cells don't actually produce heavy chain at all, and those patients are what we'd call light chain myeloma, and they produce either kappa or lambda light chains, but never both. So the excess of light chains is also a marker that we use to determine that there is an underlying abnormal plasma cell population in the marrow.
So when they're classified, it would normally be sort of referencing the heavy chain and then the light chain, like a IgG kappa. Is that right?
That's right. Yeah.
Okay.
There's probably not a lot of prognostic significance between the various subtypes, but when it comes to disease monitoring, it's important to know the subtype and the light chain type.
So what are the earliest clinical features and red flags of myeloma that GPs shouldn't miss, especially if they're presenting with very non-specific symptoms like fatigue or bone pain, or we might pick up a subtle abnormality on a blood test?
This is really the crux of it. It's such an important question because oftentimes when we look back, we can see signs of myeloma months to years before the diagnosis is made. And it's not because these signs are being missed by GPs, it's because they're often quite non-specific. And you don't have a smoking gun that helps make the diagnosis in the early stages. So the typical symptoms that we see are often fatigue, which is completely unhelpful because it's such a omnipresent symptom in all facets of medicine. But fatigue associated with constitutional symptoms like weight loss, profound lethargy, inability to manage usual activities, and that's often reflected in the blood tests as anemia as well. So patients with anemia often report fatigue symptoms. Pain is the second most concerning symptom in myeloma, and it's bone pain with often the typical red flag features. So it's persistent pain that's not responding to usual measures like rest and heat packs and analgesia. It can worsen at night time or wake people from sleep, and it's not clearly related to any mechanical cause. Sometimes patients can develop minimal trauma fractures with myeloma as their first symptom. Sneezing, minor falls, very benign, innocuous sounding injuries. But if the pain is out of proportion to that injury, then I think the suspicion of fracture needs to be raised. So clinical symptoms, quite non-specific, but pain would be the number one thing not to miss. We do talk about recurrent infections as a feature of myeloma, but I don't find that that's often a prominent symptom at the beginning. It becomes more prominent, I guess, as people undergo treatment, but recurrent infections is a fairly broad symptom that I wouldn't say was particularly indicative of myeloma. I might just say most of the time, I think the suspicion of myeloma is raised on the basis of blood tests. So a lot of patients will have blood tests for routine screening, maybe for monitoring of other conditions like hyperlipidemia, PSA monitoring, thyroid function testing. And it's important to look at the flags in the biochemical panel because patients with MGUS and myeloma will often have raised protein readings. And often that's the globulin fraction that's elevated. So raised globulins, low albumin, is a sign that something's being overproduced. There's too much protein here, and that can be a marker of a plasma cell dyscrasia. Obviously, anemia we've mentioned, raised ESR. I think that's a common investigation that's abnormal in myeloma. And then unexplained renal impairment, high calcium, and unexplained proteinuria in the urine, are also laboratory features to flag the possibility of a plasma cell disease.
This episode is one of hundreds of informative and free clinical podcasts from HealthEd. Access the entire library through the HealthEd app for healthcare professionals, which you can download today from the App Store.
So if we do detect those abnormalities, for example, on routine pathology testing, anemia, renal impairment, raised calcium or ESR, raised protein, particularly the globulins, or a proteinuria, what would be the next panel of investigations that we should order if we were starting to worry about myeloma as a diagnosis?
This is where GPs, I think, can make a huge difference because a lot of the groundwork in making the diagnosis can be done using investigations that are really readily available in the community. And it seems like a long list, but we'll go through them because they're basically blood, urine, and imaging. If we identify these abnormalities early in GP, we can really make a difference in averting disaster, dialysis dependency, pathological fractures, etc., by gathering that basic information and then referring patients in a timely manner for specialist review. So, if we suspect a plasma cell dyscrasia, if we suspect myeloma, we really need to establish that there's evidence of a monoclonal process. So, that's with protein studies and looking for any evidence of myeloma related organ damage. And that's going back to the CRAB features. So I would do a full blood count, looking for anemia. Sometimes the lab will remark on rouleau, which are a finding under the microscope of red blood cells that have coalesced together to form little piles, little stacks of red cells. And rouleau are a feature of high protein levels in the blood. Next, I'd do a full biochemical panel looking at urea and electrolytes, creatinine, including calcium. And a raised calcium level, it's also sometimes useful to do a parathyroid hormone level as well to prove that it's not due to a hyperparathyroidism. As we mentioned in that panel, we're also looking for protein in the globulins, the albumin, and the creatinine. So that will all be reflected in that panel. In terms of looking for a monoclonal protein, the three tests are useful in that case. The first is the serum protein electrophoresis. That's looking for monoclonal immunoglobulin. So these are intact antibodies. And then the second test is the serum free light chains, which are really looking at elevations of the kappa and or lambda light chains independent of heavy chains. And the serum free light chains are a way of detecting in the blood what we used to look for in the urine as Bence-Jones protein. So Bence-Jones protein is just light chains that are excreted in the urine. We don't rely on urine testing as much for diagnosing and monitoring myeloma, but it's still useful, I think, at diagnosis. And so I would recommend just a random urine test looking for protein and albumin, as well as electrophoresis, or you could say Bence-Jones protein on the request form. And with those three tests, the serum EPP, serum free light chains, and urine Bence-Jones protein, if all of those things are completely normal, then we can very confidently rule out myeloma. If any of them are abnormal, that's when we need to be looking at referral.
What about the beta 2 microglobulin?
The beta 2 is it's important for prognostication in myeloma, but it's not diagnostic. So we can see beta 2 microglobulin increase in the setting of renal failure. It can also be raised in other hematological malignancies like lymphoma. So yes, it may be automatically present on a serum electrophoresis panel in your local lab, but it's not important or required for us to diagnose myeloma.
And then you also mentioned imaging as an investigative pathway. So, what is the role of sort of a plain X-ray versus like a low-dose skeletal survey on CT?
The value of plain X-ray is certainly not as good as CT, and we know that lytic changes in bones can be missed on X-ray and very clearly present on CT scan. So we've moved away from doing whole body X-ray skeletal surveys, and we rather prefer to do low-dose CT imaging of the skeleton for lytic disease. Now, I wouldn't expect a GP to go straight to that investigation. Certainly, when you're meeting a patient for the first time and they complain of pain, an X-ray is a perfectly reasonable place to start, looking for fracture, looking for gross lytic changes. But I wouldn't be reassured by a normal X-ray if the patient's symptoms are persistent and if they've got evidence of a monoclonal protein or abnormal free light chains, then I think it would be reasonable to do a low-dose CT skeletal survey as an initial investigation, looking for lytic bone disease, and then enclosing that with the referral to help us at the hospital to triage that referral.
So you've given us a great list there that we can work to when we are starting to worry or suspect myeloma, such as full blood count, renal function, calcium, protein, including globulin, as well as urine, and also thinking about some imaging. I'd be interested to know Once we suspect MGUS or smoldering myeloma or myeloma and we're making a referral to a haematologist, who then gets a bone marrow biopsy?
That's a great question. We know that the majority of patients that we will see in clinic with incidentally detected proteins will often have MGUS. So sometimes we have to make a decision about how likely is it that this patient has myeloma, what's the probability of them having excessive numbers of plasma cells in their bone marrow. And rather than biopsying everybody, we're trying to be a little bit more evidence-based. There has been some useful tools from the study in Iceland that I mentioned that help us to predict the likelihood of having excessive number of plasma cells in the bone marrow. And so that tool is becoming more commonly used to help stratify the need for that test. But in other centers, traditionally, we've looked at the concentration of the monoclonal protein. And most cases, if the monoclonal protein is low or lowish, less than 15, and if the light chain ratio is not particularly abnormal, then if patients are completely well with normal imaging and normal blood work, we'll defer the bone marrow biopsy and consider the patient to have MGUS and monitor them accordingly.
And so, of the panel of investigations we've discussed, what should prompt an urgent haematology referral?
So we need to consider the acuity of the presentation and we need to incorporate that with the results of investigations. There's going to be situations where it may be necessary to refer the patient directly to the emergency department. And the big issue there is patients who you suspect spinal cord compression. So patients with severe back pain with abnormal neurological symptoms or findings in their legs, I think should be referred urgently for assessment in an emergency department. Obviously, patients with uncontrolled pain who may need admission to hospital for pain management, and patients with critical laboratory results, so severe anemia requiring transfusion, severe or rapidly progressing renal impairment, or severe hypercalcemia, say over 3.5 millimoles per litre. These patients are best served, being seen urgently in emergency. Outside of that situation, then, I would recommend if patients have a monoclonal protein or an abnormal light chain ratio and they have any signs that you suspect are myeloma-related organ damage, so the CRAB features, that they be referred urgently for outpatient assessment. And we usually try and see those patients within 2 to 3 weeks in our public system. That would be any degree of anemia, renal impairment above their baseline, raised calcium with suppressed parathyroid hormone, and any signs of lytic bone disease on CT or X-ray imaging. If we take those patients then out of the equation, we're left really with asymptomatic patients with otherwise normal investigations who happen to have a paraprotein or an abnormal light chain result detected perhaps incidentally. And those patients can be referred non-urgently. And we would generally try and see them within 3 months. As I said, most of those patients will have MGUS. A small proportion may have smoldering myeloma, but I think the urgency in that case is less acute.
And with those less urgent referrals that are ideally seen within 3 months, once you do your assessment and you decide this is an MGUS or a smoldering myeloma, how often do you then like to follow them up, and what would be your routine sort of investigative panel that you're using to monitor the disease progression?
So I think some centres will follow the EMGUS patients, others will discharge them back to the community for follow-up. The decision to do that really rests on assessment of risk. What's the risk of this MGUS progressing to smoldering myeloma and on to multiple myeloma? We've got a few different tools that we use to estimate that risk. It often comes down to the concentration of the paraprotein, the type of paraprotein, the light chain ratio. And in patients that are deemed to be low risk, we would often follow them once a year with blood work. So a full blood count, electrolytes, renal function, and serum paraprotein assessment. Patients who are intermediate or high risk, we'd usually see them a little bit more frequently than that. So initially 4 to 6 monthly, following them for the first 2 years. And then depending on the tempo of progression, we may continue to follow them up through the hospital clinic or then discharge them back to the community.
Okay, that's great advice, and great guidelines for us to think about when our patients are being followed up over what can be a very long period of time before it progresses, if it progresses at all, to
That's
myeloma.
right. The rate, I mean, the historical rate of progression from MGUS to myeloma was about 1% per year. So if you're detecting a paraprotein in someone in their late 70s, early 80s, there's a very high chance that it will never be an issue for them.
And as you said earlier, the life expectancy is increasing, and there'll be another podcast specifically looking at sort of therapies for myeloma, including some exciting new emerging therapies. But I'm imagining then this is going to be treated more as a chronic disease, perhaps for patients who are on their maintenance therapy. Is there anything that GPs should be mindful of for patients who might have had some initial treatment and they're now into that sort of chronic disease phase where they're just being monitored?
Yeah, this is, I think, an issue for a lot of our hematological cancers and solid organ cancers as well. Survivorship and long-term treatment toxicity has become as much of an issue now for us to think about as disease recurrence or relapse. And so we do, I think, we're going to increasingly rely on our GP colleagues to help manage a growing population of long-term cancer survivors in the community. For myeloma, at this point in time in 2026, we still don't think the disease is curable for the majority of patients. There may be signs in clinical trials that with some of our newer immune therapies, we may see long-term cure in myeloma. But the reality is, for patients in Australia in 2026, they will live with the disease until it progresses and until they pass away from it or from something else. So continuous therapy tends to be the paradigm. These patients, once they're on treatment, tend to stay on treatment until the disease progresses, until they can no longer tolerate it, or until the treatment fails for some other reason. So there'll always be communication and contact with the specialist. But in between that, we have to remember that patients can develop other problems too. And one of the biggest issues that we face in this population is infection. And so we often rely on GPs to maintain good vaccination compliance and ensure that patients are up to date with their vaccination schedule. We also see increasing rates of second primary malignancies. And that can be across the whole spectrum of secondary malignancies, particularly skin cancer in Australia, as well as hematological secondary cancers like leukemia, and the usual age-related breast, prostate, lung, etc. So skin checks and keeping up to date with other age-appropriate cancer screening, fecal occult bloods testing, mammography, pap smears, etc. That's all really important
Okay.
as well.
So, given that this is a myeloma is a condition that's often diagnosed in people in their 60s or 70s, and we're now looking at it perhaps being a longer survivorship, and unless they succumb to infection or treatment toxicities, it sounds like it could be a case where they may die with their myeloma rather than from it. It'll be either another malignancy or ischemic heart disease or a stroke or something else that may
That's
end up
right.
being what they'll succumb to.
That's right. Yes.
Okay. Well, we've certainly covered a great deal today, Nick. I wonder if you have any important takeaway messages for the GP audience.
I think it's been a great discussion, and thanks for giving us the platform to have this talk. I think the message that I wanted to convey is that we don't expect GPs to make the diagnosis of myeloma, but simply to think about it and to do those key investigations to help us make the diagnosis early. I think that can make a huge difference to the patient trajectory. I'd also want to, I guess, encourage GP colleagues to reach out for advice if they're unsure, if they're uncertain about, how urgent is this? Do I need to send this patient to hospital? How do I interpret this test that they told me to order? Please pick up the phone and call your local hematology service, because we're all very approachable and care very much about getting our patients seen in the right time frame. So I would encourage communication, and I recognize that GP is a very different environment. Time pressures are immense, and often these calls need to be made out of hours, which is completely fine. That's, I guess, the other take home that I'd like to pass on.
Well, Dr. Nicholas Webber, thanks so much for joining me on today's Health Ed podcast. As we said at the beginning, myeloma is a condition that we may see very rarely in a long career in general practice, but certainly one we don't want to miss. And you've given us a terrific approach that GPs can use when we should suspect it, and then how we might progress with the workup and referrals. So I thank you very much for sharing your expertise and insights on this topic.
My pleasure. Thanks for having me.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.